Welcome, everyone. Welcome to our Rush University Medical Center's Facebook Live. I'm your host, Steve Misek, and today my guest is cardiologist Dr. Rupa Sanghani, the Associate Director of the Rush Heart Center for Women and Associate Professor at Rush Medical College. Thank you so much for joining us today.
Thank you for having me, Steve.
And before we get started, I just wanted to encourage everyone who's watching on our live stream, if you have any questions for Dr. Sanghani on the topic of women and heart health, please share them in our comments. We'll be watching for those and be sharing some of the best ones with Dr. Sanghani to answer. So to kick things off, can you tell us a little bit about your various roles at Rush?
Yeah, so I am the Associate Director of the Rush Heart Center for Women, which was started by my dear colleague, Dr. Annabelle Volgman. We focus here on the diagnosis and treatment of women who are at risk of or who have heart disease. I, in particular, tend to do a lot of our cardio obstetrics, which is a subspecialty within this even, where I manage a lot of women who are intending to get pregnant and have cardiac disease or manage them through their pregnancies. I am also the director of nuclear cardiology at Rush and started our cardiac PET program here 3 years ago. It was the first program of its type in the area and the largest to date, and offers really the newest technology available to look at blood flow to the heart. And it marries my two interests because it's particularly helpful in women who are at risk of a type of disease called microvascular disease.
See, and you're also an associate professor as well.
Correct.
And tell us a little bit about what kind of classes maybe you teach.
So I direct our cardiology consult service and teach mostly clinically within nuclear cardiology and clinical cardiology, both inpatient and outpatient.
Gotcha. So as we know, February is American Heart Month. So today we're focusing on how heart disease specifically impacts women, which of course is your passion, as you mentioned. So while I know heart disease is as common in women as it is in men, what is unique about how it affects women?
That is a great question. So women do have what I'll call generic heart disease, which is atherosclerosis or plaque that builds up in the big arteries of the heart. So there's
Hmm.
three main arteries, and most people think of heart disease as that. These are the three arteries that sit on the heart and give it its blood supply. And we know that we can treat these if there's a severe blockage with an angiogram and a stent. What we know that's different in women is that what we've learned over time is that women tend to deposit their plaque differently than men. They are more likely to have diffuse narrowings of the artery rather than one focal area where the artery is pinched. And those are harder to treat because we can't stent along the entire length of the vessel. Women are also more likely to get what we call microvascular disease. So of the three big blood vessels, there are small branches that dive down into the heart tissue. And 2/3 of the heart circulation is actually in this microvasculature area.
Hmm.
And so that same plaque, hypertension, cholesterol buildup in the big arteries can affect the small arteries. So we know that women who come in with all purposes with angina and chest pain, and yet are sometimes told on their angiogram, oh, you don't have heart disease because there's no blockage in the big arteries, may have other underlying problems in the microvasculature. In addition, there's other unusual conditions that we know about now. One is called Takotsubo or broken heart syndrome. You may have heard about this on the news. We
Right.
know women are more prone to something called spontaneous coronary artery dissections. So there's different types of heart disease aside from generic cardiac disease, but we treat all sorts of that.
Right. And how much do we know about why these differences exist between the sexes?
So we know a lot more now than we used to, but there is still much more to learn. So some of this we know is probably the physiology of the disease is different.
Hmm.
And some of this may be secondary to the hormonal milieu, meaning more estrogen in women. Women are somewhat protected for heart disease until they hit menopause. Now, heart disease can affect women in every age group, and it does, but it is less prevalent in the younger age groups, which is why I think most people think of this as a man's disease, although it's not.
Hmm.
But something about the hormonal milieu of estrogen or the lack of it as we get older changes things for us. And we know that, again, we deposit plaque differently. The symptoms can be different. The treatment is an area that we're learning about, and it's programs like this where you have a dedicated center to women so that we can actually in-depth, see these cases, treat these women, and do research to know and learn more in the future about what's different.
Right. And who is most at risk for heart disease, especially amongst women?
Yeah. So we'll start with still, we look at the traditional risk factors. So I think the things that most people are familiar with, but patients with diabetes, hypertension, high cholesterol, tobacco use, weight if you're overweight, inactivity, or a strong family history of premature heart disease. So these are the traditional risk factors that we really want to think about. And I would say that in women in particular, we probably underestimate things like family history and then pregnancy history. I actually take a pregnancy history on every woman that comes into my clinic because we know that pregnancy can actually unmask heart disease that may manifest later on in life. In addition to the traditional risk factors, so we know that, so pregnancy related risk factors, so we know that women who have had any type of hypertension problem during pregnancy, so gestational hypertension, preeclampsia, or what we even call postpartum hypertension now, is at a higher risk 10 years down the road, actually, of developing hypertension, but also long term of developing heart disease. Similarly, a woman with gestational diabetes is at a higher risk of developing frank diabetes and increased cardiovascular risk. In addition to both of those, I would say that inflammation, which is part of how plaque deposits in the heart, probably plays a bigger role in women. So
Hmm.
we know that women who have inflammatory conditions like rheumatoid arthritis or systemic lupus erythematosus also have a higher risk. So when I assess a woman in clinic, I will screen for traditional risk factors, and including the, not just do you have the risk factor, but how well has your risk factor been controlled? I.e., if you've had diabetes, how long has it been? What have your hemoglobin A1Cs been? But I'll also do a complete both pregnancy and inflammatory history.
Gotcha. And so you mentioned pregnancy in there, and you said that that's can reveal some underlying health heart conditions. Can you tell us a little bit more about what it is about pregnancy that kind of unmasks those things or brings them to the light?
Yeah. So when you are pregnant, your blood volume actually increases by about 50%. And of
Hmm.
course, even higher than that when your heart's working hard during delivery. But all that extra fluid makes the heart work much harder than normal. So I kind of think of pregnancy as almost like a 9 month long stress test. Your
Mm.
heart's pumping very vigorously to accommodate all that fluid. And over time, if it's not able to accommodate all that fluid and all that hard work, it will reveal stuff. So we have seen women who didn't know they had valvular heart disease or at risk of congestive heart failure or different things who may manifest with symptoms during pregnancy. And again, as I already mentioned, women with gestational diabetes or any type of hypertension disorder during pregnancy is at risk later on. Unfortunately, women often have their deliveries, they get busy with child rearing and work, and the last thing they're doing is, especially in that vulnerable period of 25 to 45-ish, where you think, okay, I'm healthy, I'm fine, I'm busy taking care of everything else, don't realize that those are actually harbingers of what's to come. And so that's a group of women that I would love to see come in sooner, come in for their annual visits and their checkup, but that stress load of the volume in particular really can be enlightening during pregnancy.
And out of curiosity, is a woman who's been pregnant multiple times at greater risk still because of multiple pregnancies, or is it just sort of more indicative rather than necessarily predictive of a problem?
No, each pregnancy is different. So I
Mm.
wouldn't say that we know one way or the other. There are some women who do multiple pregnancies and are fine until the last one and may have severe preeclampsia, and that may be age related or something else that's happened. So it's really what happened during pregnancies, but each one is different. And I'll say the opposite. I have women who've had problems with the first one or two pregnancies, and the third one, maybe because we will not treat some of these women with aspirin, maybe because they had closer follow-up, did better the third time around.
Interesting. So you mentioned earlier that oftentimes when female patients come in to and having chest pains, that they often are not told that they have heart disease because especially they don't see the major blockages. Can you tell us a little bit more about what the disconnect is, where female patients are not having their concerns taken seriously about chest pains?
Yeah. Well, let's talk about symptoms first. So women
Sure.
can come in with the typical symptoms of heart disease, and the typical description of angina, the textbook definition is substernal chest pain that worsens with exercise and is relieved by rest or nitroglycerin. And women absolutely can have that, but they can also present with more vague symptoms, and that may include shortness of breath, fatigue, or heartburn.
Mm.
Um, I don't know of many women who are working and with families between 30 and 50 that don't have fatigue, so that can be really hard to tease out. Um, but there's a disconnect, I think, between even our healthcare providers understanding that all women in all age groups are at risk. Again, we're somewhat protected up until perimenopause, but that doesn't mean it can't happen in younger women. And so, for everyone, practitioners and patients, to be aware of what are your risk factors, making sure you know what's my family history, what are my numbers, what's my blood pressure, my cholesterol, did I have a problem with pregnancy? For the patients to advocate for themselves, and also for practitioners to be aware that although it's less likely, it's still there and that we need to take symptoms seriously. In general, I tell my patients that if something doesn't feel right to you, if you're having new symptoms, if you're not able to do what you normally do, and you just feel that something is right, go with your gut and come in to be evaluated.
Absolutely. And so, if you're coming in to be evaluated, what are the diagnostic options available for someone who's learning whether or not they have heart disease?
Yeah. So, well, the first step if someone is coming in is to see their primary care physician or a cardiologist. So, I see a lot of, we'll start with the asymptomatic women, the person who comes in and says, I want to make sure, am I at risk? And we love seeing those patients because we really want to be proactive and address your risk factors before you develop heart disease. The
Mhm.
first step would be to take the thorough history and physical, looking at all your risk factors, and from there, I will tailor more advanced risk testing. So I might, in some patients, recommend an advanced cholesterol profile, which checks for more than just the standard for total cholesterol, HDL, triglycerides, and LDL.
Mhm.
We now do what are called coronary artery calcium scores. Those are useful in patients who do not have a known history of heart disease. So, again, the asymptomatic woman who's coming in for risk assessment. Calcium deposits are part of the atherosclerotic process, and that's something very easily we can image. Look for it's a mini CAT scan essentially, no
Mm.
contrast associated with it. It just takes a quick picture of the heart arteries to see if there's calcium there. If you have calcium in your heart arteries, you have heart disease. And so that would change how I manage blood pressure, cholesterol, my recommendations for aspirin. For a woman who comes in with symptoms, something they're truly worried about, chest pain, shortness of breath, can't do what they normally do, then I'm going to tailor their testing depending on what the symptoms are, what I think their risk is, and what's my question. Is this something that I want to look for kind of microvascular disease as we talked about or major blockages? So from there, I might proceed to stress testing. An angiogram, if I'm really worried, that's the diagnostic procedure where we go straight into the heart arteries, take a look, and if there's a blockage, we can fix them right then and there. Or I might do a CAT scan angiogram. And then again, as I've already mentioned with cardiac PET, we can actually look at women who I'm worried about microvascular disease. And so I can actually look at the blood flow to the heart and actually make a measurement of what amount of what amount of blood flow is getting to the heart tissue directly.
Interesting. And so when you have someone who does present with heart disease, obviously there are a range of options for treatment. What do some of those include?
Yeah, so treatment of the disease is somewhat similar right now for men and women. So women who have atherosclerosis, whether it be in the large or the big vessels or the small vessels, the general treatment would be an aspirin, blood pressure treatment, and cholesterol treatment. Now, which drugs I might pick within there depends on what other problems that woman has. But those are the three big areas we're going to start with. If there's a tight blockage that's causing the symptoms, stenting is just as efficacious and recommended in women. And unfortunately, many women are often kind of undertreated with that. So we want to make sure that we've really looked at the vessel carefully and seen if that blockage is really tight enough. Women, though, can be more prone to what we call spasm or the microvascular disease, and the treatment there is a little bit different. There are medications we can use to help the spasming of the artery. There are newer treatments being looked at for microvascular disease as well.
And you mentioned preventive measures as well when we were talking a little bit earlier. Generally speaking, what are some good preventive measures that people can take to help prevent heart disease?
That is a great question. And I really want people to be proactive. So first step is to know your history. Again, know your family history and what your risk for, know your own pregnancy history, see your doctor regularly, get your blood pressure, your cholesterol checked. Stop smoking. That's probably the single most important thing you can do. I tell patients that I can treat you with medications till I'm blue in the face, but if you're still smoking, it almost negates all of it.
Mm.
So that's critically important. And that includes vaping, e-cigarettes. I think there's a lot of misinformation, but we worry about any of that nicotine and affecting the heart arteries. Getting as much exercise as possible. We recommend 150 minutes of moderate intensity exercise per week. And if you're doing truly high intensity exercise, that can be cut in half to 75 minutes. I think that that can sometimes be daunting to patients.
Mhm.
I tell my patients just move. It doesn't have to be wearing spandex. It doesn't have to be a chunk of time. You're busy. We're all busy. If you can get to the gym and find a half an hour block of time, great. But if you can't, every little bit that you move your body, whether it's going for a brisk walk during the middle of the day, climbing that extra flight of stairs, throwing in a few squats and lunges in between cooking dinner and taking care of the kids or whatever else you're doing, every bit of movement helps. So move your body as much as possible. Try and get true cardiac exercises if you can. And then diet. It's watching and making sure that you're making healthy choices in what you eat. And that again goes back to the basics. I tell patients fruits and vegetables. We want you to eat food, the stuff that you learned about in kindergarten that grows in nature in its most natural form. Um, Mostly plants, so more fruits and vegetables than processed foods, and less of the animal products if you can. I will tell patients to, it's all about balance and about planning. So
Mm.
I personally try to eat very clean during the week so that then when I'm out with friends, or for me, it's a social thing, and I think for many people, you're allowed a little indulgence. That's what life is about. But if you're
Mhm.
planful in how you eat, then you're allowed that little bit when you don't, and you won't feel deprived. But really paying attention, it's the day-to-day maintenance of saying, I'm making a choice here in what I put into my mouth to eat so that I can prevent heart disease. For women, I would say the other two big things are sleep. Getting enough
Mm.
sleep and enough rest and stress reduction are quite important. And it's easy for me to say that. I know it's hard these days because everyone's so busy, and with everything in the last 2 years, everyone is feeling a lot of stress. But
Right.
any way that you can spend 2 minutes during your day, start your day with maybe 2 minutes of closing your eyes and having some type of mini meditation where you're setting your intention for the day. setting an alarm on your phone where you can take a minute, maybe every 2 hours, and just close your eyes and take some deep breaths. That stress reduction really can make a big difference as well.
Interesting. Well, I think I might be taking some of those deep breaths later today as well for my own stress reduction. Moving on, if you could tell me a little bit more about the Rush Heart Center for Women, it sounds so interesting.
Yes, of course. So, we are a group of doctors and APNs who specialize in the care of women who have cardiac conditions. So, we do everything from risk assessment. So, I have plenty of women who come in and say, I've been hearing more about this. I want to know if I'm at risk. I want to know what I should do. And so that's great. That's true preventative medicine. We can do a very cardiac specific risk assessment, tailor it to your history, and give you guidance from there on do you need to see us or just your primary, and how often, and what to do for the future. For the woman who has known heart disease, whether it's generic coronary artery disease, valvular disease, palpitations, or arrhythmia, we of course treat all of those. And then again, the new novel conditions. So these are the women who say, I've already had all the testing. I went to my community doctor. I'm having chest pain. They've done this, this, and this, and they can't find out what's wrong with me. So we get a lot of patients like that where I'm looking through records, maybe recommending more advanced testing that a place like Rush would have. And then I would say the last big component is the pregnancy related heart disease. So I see a lot of women prior to pregnancy, as we are seeing women getting older and older, getting pregnant. Many times I see women prior to IVF. They're older, they may have already have hypertension or diabetes or obesity before they're going to go through a pregnancy. We want to make sure that they're safe to do this and that we have optimized their heart as much as possible. And then, of course, I manage women through their pregnancy, and in particular, I would say postpartum. The first 2 to 4 weeks after delivery is actually a very vulnerable time with a
Yeah.
lot of changes in what we call the hemodynamics. So your blood shifts, blood pressure, heart rate, everything changes very dramatically in those first 2 to 4 weeks. And that can put a real stress on women. And so I will actually see my postpartum patients almost weekly for that first 2 to 4 weeks, depending on what their condition is. So we really try to provide a comprehensive approach from risk, treatment, and all aspects of women and heart disease.
Yeah, it sounds like it's truly comprehensive and a real team effort. So we have a question from the audience. Our follower John asks, are women's heart attacks any different from men's? And if so, why?
That is a great question. So again, generic kind of heart disease, what's called a heart attack or an ST elevation MI, is usually due to a blockage in the heart arteries. Those are similar. We can go in, we can fix and stent those. But again, women tend to put plaque more diffusely, so sometimes it's hard to treat. There's a
Hmm.
whole new spectrum of heart disease, though. One is called MINOCA, or MI, with non-obstructive coronary disease, that we're seeing in women. So these are women who come in with all purposes like a heart attack. They have chest pain, they may have EKG changes, and they may even have the positive enzymes that we look for. And yet, when we do the angiogram, there's no obstruction or blockage in the three big epicardial coronary arteries. And these are the women that we see usually coming in for a second or a third opinion because they're like, well, I had a heart attack, and yet they didn't find anything. They didn't do anything. So these are women that I would look for microvascular disease, spasm, some of the other more unusual conditions.
Interesting. Well, we have to wrap it up, but thank you so much, Dr. Sangani, for taking the time to talk with us today. And thanks to everyone who tuned in and watched and participated and shared their questions with us. We greatly appreciate it. Please visit rush.edu for more information about all things heart disease and women, and stay tuned for more live broadcasts from Rush in the near future. Thanks, everyone.
Thank you.